All right, hello everyone, this is Dr. Pruett. We are back for continuing our series on 12 leads. Today we're going to be talking about bradycardia, how to recognize it and how to treat it. Just quick definition right out of the gate. Bradycardia is defined as a heart rate in an adult that is less than 60 beats per minute. Now, this can be normal in young, healthy people. Typically, you're going to see this in very fit individuals that are athletes or marathon runners. And what this means is their body is so efficient that their heart is not having to work hard while they're at rest because their cardiac output is maintained with a lower rate. Quick reminder on the cardiac conduction system. The heart is run by electrical impulses that are inherent to the heart. So you have a sinoatrial node up here in the right atrium that sends an impulse through the atria that causes them to contract and send blood into the ventricles. And the impulse then goes to the AV node, pauses for a second, and then is conducted through the AV bundle or the bundle of His to the right and left bundle branches to cause the ventricles to contract and eject blood to the rest of the body where it needs to go. Now, when we look at cardiac conduction, each area of the heart, the three big areas, the sinoatrial node up here in the atrium, the AV node right between the atria and the ventricles, and then the ventricular bundles, each have an intrinsic rate. So usually a good rule of thumb is you can tell that a impulse is coming from the sinoatrial node if it's coming at a rate between 60 and 100 beats per minute. Now we all know that the heart can beat faster than 100, so this does have the ability to go faster than 100, but usually at rest in an average individual it goes between 60 and 100. The AV node has an intrinsic rate of 40 to 60. This is important as we're getting into evaluating our bradycardia. So say for whatever reason the SA node is not working or is not conducting impulses, our heart is a redundant system, right? Because life depends on our heart beating. And so if the sinoatrial node is broken for whatever reason, the AV node has the ability to take over, but the best it can do is only pump at 40 to 60 beats per minute. Now let's say that both the sinoatrial node and the AV node are taken out. Our heart still has some redundancy built in because it's so important to keep this organism alive that the ventricles are going to do their best to take over and organize some cardiac activity to pump blood to where it needs to go. But if the ventricles have taken over, the best they can do with their automaticity and their intrinsic rate is between 20 and 40 beats per minute. So if you have a bradycardic patient, you can quickly look at the rate and try to think where that rhythm might be originating from. If it's 40 to 60, it might be coming from the AV node. If it's 20 to 40, it might be more ventricular in origin. Very important. Back to the fundamentals, we want to read an EKG the same way every time. The 5 things I like to think about when I look at a 12 lead are ask myself, is this sinus rhythm? Is there a P wave before every QRS? Is the rhythm fast or slow? Is it regular or irregular? Is it wide or narrow? I look at the QRS. It should be less than 120. What are my intervals and what are my axis? Namely, I'm worried about the QT interval. Is it less than 500? And then lastly, I look at ST elevations or depressions. Important to note that a 4 lead is only going to give you 25% of the picture. Same with a quick 6, it's only going to give you half of the picture. So make sure you're getting a 12 lead on any patient you think that needs it, especially as we're talking about bradycardia today. The complaint doesn't necessarily need to be chest pain to prompt you to get a 12 lead. If you have someone who's weak or dizzy or short of breath or is having syncope, all of these are chief complaints that need a 12 lead to look at the heart because the problem could be cardiogenic in origin. Now that said, we are dealing with bradycardias, and one of our key questions with bradycardia is going to be, how do those P waves match up with the QRS? Is that sinoatrial node working like it should and communicating like it should with the ventricles? And sometimes that's hard to tell in a 10-second 12 lead strips. So it's okay to get rhythm strips and try to further evaluate those P waves and look for AV blocks. Now, starting out with sinus bradycardia, here we have an 86-year-old. My first question, is there a P wave before every QRS? My answer looks like yes. Okay, so we know this is sinus in origin, but is it fast or slow? This is a very slow rate. This is 42. Is it narrow or wide? This is a narrow QRS. I look right here, it's 114, right? But then I look at my intervals. What do I see here? Prolonged QT interval. This is greater than 505, and this is going to be a common theme that you see with bradycardia. As the heart slows down, that QT interval is going to get longer and longer, and this patient's going to be at increased risk for torsades. So here we have a sinus rhythm that's slow and narrow with a long QT. This is sinus bradycardia. Here we have an idioventricular rhythm, and this is just a fancy name. Remember at the very beginning we talked about the intrinsic rates of the heart, whether it comes from the sinoatrial node, the AV node, or the ventricles. Here we have a 62-year-old with a heart rate of 35. So automatically I'm thinking, maybe this could be ventricular in origin, because I know that the rate, if it's coming from the AV node, will typically be between 40 and 60. So I'm looking for P waves. Do I see P waves? I don't think I see P waves anywhere. Okay, that confirms my suspicion. This isn't coming from the sinoatrial node. And then I look at my QRS. It's 150. So I know that it's coming from below the ventricles, right? Because it's taking longer to conduct through the different bundles below the AV node. So I have a wide QRS with no P waves and a rate of 35. I would call this an idioventricular rhythm. So this is a heart where the sinoatrial node has failed, the AV node has failed, and the heart is doing its best to pump blood, but it can only do that at a rate of 35 beats a minute. Now again, importantly, we mentioned before, you can see the QT here is 553. So remember that we're at increased risk for torsades if it's greater than 500. So again, this is a common theme. We're seeing a bradycardic patient with a long QT. Here's another idioventricular rhythm. I can't imagine that this patient looks very well. This is super slow, super wide. Doesn't look like a strong squeeze to me. We have an 89-year-old with a heart rate of 27. And so I look for P waves before every QRS, just like we start with every 12 lead we look at. I don't see P waves. The QRS is wide. It's 160, so that tells me sinoatrial node's broken, right? No P waves. AV node is not conducting, right? Because my QRS is wide, so this rhythm is originating below the AV node from the ventricles, and it's at a rate where I can tell that the ventricles are doing their best to try to take over to pump blood. So again, this is an idioventricular rhythm with a rate of 27. And again, just like before, here we have a QTC of 605. So this is a really long QT interval. Here's another one just to hammer this home. This is a 63-year-old with a heart rate of 36. I'm not seeing P waves before the QRS. I see a wide QRS of 150, so I know this is not coming from sinoatrial node. This is not coming from AV node. This is a rate of 36. It's an idioventricular rhythm, again, with a long QT, 600. So what are the symptoms of bradycardia? If you can imagine, this is a heart that's either not beating fast enough or not getting blood to where it needs to go. The patient might be complaining of generalized weakness. They might be tired. They might feel dizzy. They might have diaphoresis, be a little bit confused, or actually pass out. These are all symptoms you might hear the patient complaining of. They need to prompt you to get a 12 lead because the problem with generalized weakness could very well be cardiogenic. And this all has to do with cardiac output. So there's two things that dictate how good the heart squeezes blood to the rest of the body. The first thing is the heart rate. How fast is the heart going? That's how fast blood will be squeezed out, right? And then how much blood is being ejected from the heart with each beat. And so heart rate depends on nerves, right? We were just talking about electrical conduction, and some of it can be due to hormones, namely adrenaline or epinephrine. That'll be important in a minute. And then stroke volume, that's how strong the heart muscle is, right? And then what kind of vascular tone the patient has and how much volume there is. But today we're going to focus on the rate because that's an important part of cardiac output. When I think of what could cause bradycardia and how I'm going to treat it, there's basically 3 things. And this is actually, it's a little bit morbid, but it's true. Bradycardia scares me in a patient way more than tachycardia does. And if you remember this algorithm, bradycardic patients die, D-I-E. Drugs can cause bradycardia, ischemia can cause it, and so can electrolytes. The drugs that are most common cause of this are beta blockers. This is a very common prescription in patients with underlying heart disease. And essentially what it does is it goes back to the fight or flight system and the rest or digest system. And it acts, we know that adrenaline, epinephrine, makes the heart beat faster, right? It's the fight or flight hormone, and it's going to increase cardiac output so you could run away from the saber-toothed tiger if you're being attacked. What a beta blocker does is it essentially sits on the receptor that's waiting for adrenaline to bind and stops adrenaline from binding. And so by tying up that binding site, it forces the heart to not beat any faster than it should. And in a patient with a sick heart that can't handle an increased load, beta blockers actually help because they're relieving the stress off of the heart. But as a consequence of what that does is it slows down the heart. And there's times when the heart does need to beat faster, and it doesn't allow the heart to do that. And so patients might get symptomatic from that. It's going to slow, the beta blocker is going to slow the sinoatrial node impulses. It's going to slow the ventricular conduction rate, and it's going to increase the diameter of the blood vessels. And so it can really affect cardiac output. Remember, we were talking about cardiac output depends on stroke volume and heart rate. And if more of the volume is inside the blood vessels and the heart rate is decreased, you could very easily get patients that are weak and dizzy and having syncope. And so if you have a bradycardic patient, especially one that's older that has a history of heart disease, make sure you ask about the drug doses that they're taking and any recent changes to their medication, because very frequently you'll find a patient that's on a beta blocker and it's actually their medication that's causing them to have these symptoms, especially if there's a recent change. Now, occasionally also you'll get a patient that overdoses on beta blockers, and this is an incredibly serious and frequently fatal overdose. And so if you do see a patient with a beta blocker overdose, treat them very seriously because they're going to get very sick. Okay, so bradycardic patients die. We covered the drugs, beta blockers being number 1. Number 2 is ischemia, die, D-I-E, drugs, ischemia. And usually ischemia that causes bradycardia is going to come from an inferior STEMI. And if you think about it, the leads that show you the inferior portion of the heart are going to be leads 2, 3, and AVF. 2, 3, AVF are looking here at the bottom part of the heart and up here at the right atrium. And if you think about the territory of these, there's one blood vessel that feeds the sinoatrial node. It's actually the sinoatrial nodal artery, and then the right coronary artery. And both of these things, if there's an inferior infarct, this not only is going to take out this muscle up here, but can also affect the electrical conduction of the heart. So if you have a patient who's having an inferior STEMI, it's very common for them to develop either symptomatic bradycardia or some sort of AV block, which will be a whole different lecture. But when I get a inferior STEMI, you can kind of anticipate what's going to happen with this patient is they're going to get bradycardic and they're going to develop some sort of AV block. So here we have, let's read it the same way every time, even though we're all looking at something that's pretty obvious here. We have a 37-year-old, which is pretty shocking, with a heart rate of 58. So first thing I do is I look for P waves before every QRS. Do I see them? I'm not sure that I do. Maybe here, but they're definitely not before every QRS, right? Is this wide or is it narrow? You can call it narrow, QRS 90. So maybe it is coming from above the ventricles, but we know it's not sinus, so where's it coming from? Probably that AV node, right? This is a junctional rhythm. Is it regular or irregular? This looks very irregular to me. And then our intervals and our axis, our QTC is 427, that's okay. Lastly, and importantly, we look at ST elevation and depression. So what do I see here? I see elevation in 2, 3 AVF. Those look like tombstones, right? And then next I look for reciprocal changes. So I'm seeing ST depression in V2, V3, V4. So I would definitely call this an inferior STEMI. And here's another one. This is a 72-year-old with a rate of 55. I look for P waves before every QRS. Do I see them? I see one here, but they're definitely not before every QRS. Maybe there's one here, but pretty irregular, right? How's my QRS? It's 130, so this is a wide complex bradycardia with a rate of 55. That looks, I'd call this fairly regular, kind of marches out, huh? So wide complex bradycardia that's regular. Let's look at our axis and intervals. QTC is 460. Axis is up. Lastly, we look at our ST segments, 2, 3 AVF. There is ST elevation. I see some inverted T waves in V2, inverted T waves in AVL. I would call this an inferior STEMI. So once again, inferior STEMIs, don't be surprised if they get bradycardic or they develop AV blocks, because they're taking out a large portion of that electrical conduction system up there in the right atrium. And here's just another inferior STEMI that's bradycardic. So what do we do with inferior STEMIs? Most important thing we do in anyone with acute coronary syndrome is give them aspirin. This is the only thing that's proven to help with mortality. So if they're able to control their airway and take oral medication, give them aspirin. You also want to think ahead. I always try to be a step ahead of my patient and recognize what's going on and ask myself, if they were to get worse, what would happen next? And then be ready for that. And so if you have a bradycardic patient who is having a STEMI, these are inherently unstable. And so the next thing you want to do is increase that heart rate, right? And help that heart beat. So you want to be ready to pace. I would have the pads on this patient. Think about how you're going to do that. Which buttons are you going to push? How are you going to capture? What do you want that rate to be? And what is that going to look like? And if you're not able to do that, what is going to be your next move? Should be epinephrine. And epinephrine does a couple things for us. Remember, we're trying to increase cardiac output in our unstable patients. And so epinephrine is essentially adrenaline, and that's going to increase the patient's heart rate inherently, which is good, right? You want to increase the heart rate so you're increasing their perfusion to their brain. And it's also going to constrict blood vessels. And so it's going to therefore increase the stroke volume and the blood that's ejected with every beat of the heart. As we're further thinking about things that cause bradycardia, electrolytes is another very important thing to consider. The most common electrolyte abnormality here is going to be hyperkalemia. You need to think about this problem in your patients with renal failure or who have had recent crush injuries or are profoundly acidotic. Now, what happens here is that the way our bodies are made is our cells are essentially batteries. And the way any battery works is the flow of current. And outside of our cells, we have a whole lot of sodium. And inside the cells, we have a whole lot of potassium. And the flow of sodium and potassium across the cell membrane is what helps cells do their job and creates the electricity they need to function. Well, when cells are broken or disrupted or die too fast, or there's too many of them that are ruptured, potassium is released, and this can be overwhelming to the bloodstream. This is particularly important in crush injuries or in acidosis because as the pH changes in the body, the cell membrane can become weak and then potassium is released into the blood. And this can have profound consequences on the way that the heart beats. And so what you're going to see in patients that have too much potassium in the bloodstream where it's not supposed to be and outside of the cells where it is supposed to be, first thing you're going to see is peak T waves. Next thing you're going to see is the QRS start to widen. And then as potassium starts to creep up and get higher in the bloodstream, you're going to see that QRS turn more into a sine wave and start to get really wide and really slow. And the slower and the wider that QRS gets, the more severely ill your patient is, and the more important it is that you act very quickly. And so if you get to, let's say, a dialysis patient with renal failure and they're bradycardic and they have a wide QRS, this is a patient that's about to code, and you need to act quickly. So here we're looking at a 12 lead of likely, let's say, a dialysis patient. We have a 77-year-old here with a heart rate of 44. So immediately you're thinking about bradycardia, right? You're running through the algorithm in your head. DIE. Is it drugs? Is it ischemia? Is it electrolytes? I'm going to look for P waves before every QRS. I don't see them. Is it fast or slow? We know that it's slow. Is it regular or irregular? Looks pretty regular to me. Is it wide or narrow? This is a wide QRS. Our QRS is 140. Our normal number we're looking for there is less than 120. So we have a wide QRS that's slow. Next, I'm going to look at my QT. It's 548, so I have a long QT here as well. And then I look for signs of ischemia. So I don't see any ST elevations or depressions. But as I'm looking at these ST segments, what do I notice? I notice really tall peak T waves. So, oh my goodness, here I have a dialysis patient with peak T waves and a bradycardic rhythm with a wide QRS. This is a patient I need to treat immediately. And here's another one, very similar presentation. I have a 60-year-old, and we don't have any computer-generated intervals up here to help us, but you can use your eyes. I do see a P wave here before this QRS. I think it is, I would call this sinus in nature, but it is wide. It's greater than 3 boxes in the QRS, and it's pretty regular. But what do I see? I see big peak T waves. So I have a bradycardic rhythm with a wide QRS with big peak T waves and also some signs of ischemia, right? Because these ones are flipped upside down. This is a severely hyperkalemic patient. How am I going to treat it? First thing I'm going to do is I got to move that potassium where it needs to go. And one of the easiest, quickest things you can do to move potassium out of the blood and into the cell is to give albuterol. And it'll be 15 milligrams per nebulizer. That's going to actually help correct your problem. Now, the other thing you need to do is you have an inherently unstable heart right now. And so the next thing to give through the IV will be calcium chloride. Now it burns, but this is important to give because it's going to stabilize that heart and stop that QRS from getting any wider or turning into a sine wave. And so you can actually watch as you give the calcium, the QRS should narrow before your eyes. But realize this is not going to affect your potassium level at all. It's just going to stabilize the heart. So if you're trying to get potassium where it needs to be, you need to be giving that albuterol as well. Here's another look at a bradycardic 12 lead. We have an 89-year-old here with a heart rate of 27. So let's look, just like we do every time, let's look for P waves before every QRS. I'm not seeing P waves. This is not sinoatrial in origin, right? Do I have a wide QRS? Yes, it's 160, so it's likely ventricular in origin, which matches with what we know about intrinsic rates, right? The sinoatrial node's broken, the AV node's broken, the ventricles are doing their best to take over, but the best they can do is a rate of 27. So we have a wide QRS, no P waves, it's pretty regular, and the QT is really long as well. So if you have a long QT, realize that there's different things that can cause this. Potassium, magnesium, calcium can cause it. Antis, as I like to refer to them, antibiotics, antiemetics, antipsychotics, antiarrhythmics. All of these things can make your QT longer than it should be. And then the hypos, hypothermia. This absolutely can cause bradycardia and long QT. Hypothyroid can do the same thing, and then just all by itself, bradycardia will kind of stretch everything out and cause that QT to be long. Now, where the QT gets dangerous is when it's greater than 500. The patient is at risk for spontaneous torsades, and so what we give for that is magnesium. You want to give 2 grams over 10 minutes, and be ready to give this in your patient that has a long QT that's greater than 500. So when we're thinking about how we're going to treat bradycardias, the first thing you want to think about and consider would be atropine. So in our guidelines, we have that you can give 0.5 milligrams by IV or IO every 3 to 5 minutes. Now, there are certain times atropine is really not going to help. You have to have an intact electrical conduction system for this to actually work. So if you give it once and you realize that it's not working and your patient becomes more unstable, that being they're unconscious, unresponsive, hypotensive, or they just start to look worse, you want to be ready to pace. And so have those pads on your patient, be ready to use that monitor to do what you need to do to increase that heart rate. And if you're not able to pace or pacing isn't working, the next thing you can do to help increase that blood pressure and that perfusion to the brain and the other end organs is give epinephrine. And that's going to help increase your heart rate and increase the vascular tone so you can ultimately increase your cardiac output. If you need to, you can start an epi drip. This is in the guidelines, but I just wanted to review it really quickly with you. You take 1 milligram of your cardiac epi and 250 mils of normal saline. That's going to give you 4 micrograms in every cc or every 10 drops. So you're going to attach a 10 drop drip set and you're going to start at 30 drops per minute. That's 1 drop every 2 seconds. And so that's going to mean that if you're doing 30 drops, it's going to be about 12 micrograms a minute. And if you need to review that math, it was good for me to review when I was putting this slide together. I think it's always a good thing to go over because these epi drips can be helpful on our post-ROSC patients and they're also helpful on our bradycardic patients. One important note about pediatric bradycardia is if you see a child that has a heart rate lower than it should be, very rarely do children have underlying cardiac disease. Usually pediatric bradycardia is due to a respiratory problem. So before you get way into the weeds on their 12 lead, make absolutely sure you're addressing their airway and you're adequately ventilating and providing oxygen to that child, because frequently just by correcting the respirations and the oxygenation, you're going to correct the bradycardia. And that's all I have for bradycardia. If you have any questions, feel free to reach out to me or contact your 7-8. Thank you.